Welcome to the third lesson in our lectures on POCUS for women's health. This lecture is going to be focusing on second and third trimester ultrasounds during pregnancy. As a review of last lesson, we talked about POCUS and ectopic pregnancy and how, because of the risk, oftentimes POCUS is not the diagnostic tool that should be utilized in evaluating an ectopic pregnancy. We did talk about how in select patients, visualizing an IUP can effectively rule out an ectopic, but that most commonly, when an ectopic pregnancy is present, a normal ultrasound is the most common finding. While not common, there are some things that are suggestive or diagnostic of ectopic pregnancies, and finding these things can help our diagnosis, but ultimately, we cannot rule out most of these cases and shouldn't using point of care ultrasound alone. Today, however, we're going to be talking about something that does have really good evidence for its use, and that's the use of point of care ultrasound for second and third trimester. We're going to talk about fetal lie, presentation, assessing fetal number and amnionicity and chorionicity. We'll talk about assessing the fluid. We'll look at some placentas, and then we'll talk about measuring baby for growth scanning. The first question to ask when looking at a second or third trimester pregnancy is, where's the baby? So let's look at how we can assess that. First, we talk about fetal lie. So fetal lie refers to how the fetal spine is positioned relative to the maternal spine. So here we see an ultrasound that is showing a fetus, and we can clearly see here the spinal canal and the vertebral bodies of this baby. And so how we do this is by finding this mid-sagittal view of the fetal spine and then comparing, based on the way our transducer is located, we compare how that compares to the maternal spine. And we, like very few things in medicine, actually get a multiple choice answer for this, which is longitudinal. So that means baby is either cephalic or breech, which we'll talk about next. Transverse, where they're lying sideways inside the gravid abdomen, or oblique, where their spine is at an angle to the maternal spine. Once we determine the fetal lie, the next question that we ask is what presenting body part or what fetal anatomy overlies the birth canal, which is referred to as fetal presentation. Assessing presentation depends on using the curvilinear probe in the transverse orientation. You'll place it just superior to the pubic symphysis and fan the probe down away from you and into the pelvis by pushing the transducer top away from you. This will identify the fetal part in the lower uterine segment. Here are some examples of variable fetal presentations. So in the upper left-hand corner, we see a cephalic presentation. And we can tell this because we have a bright hyperechoic, smooth contoured oval with anechoic structures on the inside. And this represents the fetal head. And in certain views, we'd be able to see parts of the fetal brain, but our gain doesn't look like it's high enough in this image to determine that. Here we have a breech presentation. So we see two little butt cheeks and a little intragluteal cleft, and that represents the fetal behind, kind of sitting over the cervix, so this presentation would be breech. And then here we see a compound presentation, or we see what looks like probably a little foot right here. This is probably a butt cheek. And so anything that isn't very clearly head needs to be followed up. And that's a pretty easy finding. But this is a footling breech here. This is a frank breech, and this is cephalic. The next question we have to ask, which is normally something we already know before we're doing the exam, but let's say we get an undifferentiated patient that comes in, is how many babies are there inside the gestation sac? Is there one baby, or are there multiple gestations present? Assessing the number of fetuses inside a gravid abdomen seems like it'd be pretty easy. Here we see an image of a twin pregnancy, and you can clearly see two little heads kind of bopping around in there with twin on the right, kind of it's working it out there at the end. But to be honest, sometimes this can be pretty difficult, especially the later in the second trimester and into the third trimester that you get. So I recommend that this is something that you start assessing for in any patient that comes in that has an undiagnosed pregnancy as soon as possible, because it will give you the easiest view to determine the number. The method of doing this starts by putting the probe in the sagittal orientation in the left upper quadrant. And what you'll do is you'll translate laterally in grid lines, keeping the transducer perpendicular to the table to avoid imaging one head in multiple planes and accidentally thinking that there are two. Once you've gone in one direction, you flip your probe around to the opposite transverse orientation and start again, starting in the left upper quadrant, translating inferiorly in grid lines. If you do see multiple gestations, count the number by counting the number of fetal heads you see, and then determine, if you can, the chorionicity and the amnionicity, and refer those patients for a formal study to confirm. Determining the chorionicity and amnionicity helps us determine the risks associated with twin pregnancies. A couple of findings that you may notice are dichorionic diamniotic twins, which have a lambda sign, which is this hyperechoic structure that exists in between the two fetuses. And you also see this little peaked section joining where that intra-twin membrane is connecting to the placenta. And so you'll see placental tissue sort of extend itself in between these two separate gestational sacs. So these are dichorionic diamniotic twins. Compared to that, we have the T sign, which the T sign represents a monochorionic or diamniotic twin. So these twins are sharing the same placental origin. However, they only have one membrane in between them in two separate gestation sacs. So in this case, while there's one chorionic membrane that's surrounding the fetuses, there's a separate amniotic membrane that divides them. So instead of getting a nice lambda or a peaked interface with the placenta, instead we see what we call the T sign, where it's much flatter. And we'll show you an example of this on the next slide. Lastly, we have monochorionic monoamniotic twins, which show no intertwin membrane and only one placenta and gestational sac. So here are some examples of each of those. This is an example of di-di twins, and here we see the membrane. And a couple of takeaways is that this intertwin membrane is much more thickened than we'll see in our monodi twins. And we see that the placental interface sort of has this peaked appearance. It seems to sort of come up into a mountain as we traverse this membrane between the twins. We can compare that to a monodi twin, which has a much thinner membrane because it's only one layer, and it's not peaking where it's interfacing with the placental wall or with the chorion at all. And then lastly, we see mono twins, which do not have any separation between them in view, and are the rarest of the findings that we see. So if we do indeed have a singleton gestation, we can go on assessing some of the other findings in second and third trimester. If there is a multiple gestation, I would recommend that we not do those and send those off for formal studies just because of the complexities with managing two fetuses and finding those measurements. However, if it's a singleton pregnancy, the next step is looking at the amniotic fluid and assessing to see if there's a normal amount of fluid surrounding the fetus. So historically, you might have been taught about AFIs or amniotic fluid indices, but this has really fallen out of favor. And in fact, in the most recent AIUM and ACOG recommendations, they recommend the deepest vertical pocket over the amniotic fluid index for assessment of amniotic fluid. And the reason for this is that A, it's easier to do, it results in fewer obstetric interventions without a significant difference in perinatal outcomes, and B, it's a lot quicker. So let's do it that way. Assessing the amniotic fluid with the deepest vertical pocket depends on having the probe in the sagittal orientation. Similar to when we were looking for the number of fetuses, you scan the whole uterus again in a grid from left to right and right to left, kind of crossing back and forth over the entire pregnant abdomen. And you'll identify the deepest pocket of fluid that does not contain any cord or fetal parts inside. Keep the transducer perpendicular to the table for the best assessment. You should find a pocket that's at least 1 centimeter wide, and the definition of normal using the deepest vertical pocket method is anywhere between 2 and 8 centimeters. If there's less than 2 in the deepest vertical pocket, centimeters of fluid, then that would be diagnostic of oligohydramnios. Meanwhile, if there's a pocket that's greater than 8 centimeters in depth, that could be an indication that there might be polyhydramnios present. The next assessment in our second and third trimester ultrasounds is looking at the placenta. And there's two questions that we're asking here. First, where is the placenta located? And two, is there evidence of placenta previa or not? Start by assessing the placenta once again using the sagittal orientation and scan the whole uterus in a grid going in order from one side of the abdomen to the other. Once you see the uterus, note its location and then slide inferiorly or translate your probe inferiorly to find the inferior edge. You need to verify that this edge does not come close to or overlie the cervix. And a couple things that can trip you up here is that bladder fullness and if the patient is having contractions can interfere with your assessment. So if the bladder is really full, it can put some pressure down here on the cervix, and that can make it seem as if the placenta is actually lying higher up than it is or lower down than it really is. Similarly, if the patient is contracting for whatever reason, if they're in labor or early labor, what can happen is that this lower uterine segment contracts and can give you a false placenta previa that's really not present when the uterus is relaxed. Placenta previa is a spectrum of disease where the placenta encroaches or actually covers the internal cervical os. It's classified by either a low-lying placenta previa, where the placenta is not actually covering the os, but does lie within 2 centimeters of the opening. The marginal placenta previa, where it abuts the internal os, and complete placenta previa, which covers the internal os. Now, the placenta appears to migrate, usually more fundally as the pregnancy progresses. So this warrants future follow-ups if you do happen to notice this early on in pregnancy. However, the difficulty of assessing this and the care and delicacy with which you have to examine these patients often means that we need to be formally ultrasounding them through a radiology department. Another thing to be aware of is the presence of vasoprevia. So vasoprevia is a finding that can consist of fetal blood vessels that overlie the cervical os with or without placenta nearby. These arise either from a velamentous insertion of the umbilical cord or from a bilobed placenta, and this is detected with color Doppler. This is an advanced skill that I don't expect all of our residents to be able to know how to do. However, as part of the routine anatomy scan and then follow up for any identified anatomical challenges or anything on the placenta previa spectrum, these would require serial ultrasounds to further evaluate. Next, we can talk about fetal biometry, which is basically asking the question, is the fetus growing normally, or is the fetus an appropriate size relative to other pregnancies at a similar length? And fetal biometry is divided into 4 separate categories of measurements. The first is the biparietal diameter. Then we look at the head circumference in the same plane. Then we move down to the abdomen and take a circumference of the abdomen. And lastly, we measure the femur length. Biometry is less accurate than early ultrasound for dating a pregnancy and gets less accurate the farther along in a pregnancy that we are. So redating should only be done according to the ACOG, Society of Maternal Fetal Medicine, and AIUM guidelines. First section of our fetal biometry consists of measuring the biparietal diameter of the fetal head. We start off in a transverse cross-section, and our landmarks to help us identify the correct plane are our thalami and the cavum septum pellucidum. I'm going to highlight those right now. So we see the thalami are in the middle of the brain on either side of the developing ventricles, and the cavum septum pellucidum lies in the midline along the falx cerebri, visualized posteriorly. Now, the falx cerebri should bifurcate the head and represent a symmetric midline, and we should see cerebral hemispheres on either side. And of note, we don't see any cerebellum. So cerebellum measurements are too low in the fetal skull and give us inaccurate measurements. Lastly, we take the measurement of the outer edge of the proximal bone, parietal bone, to the inner edge of the distal parietal bone, and make sure that our measurement is as perpendicular as possible to the falx cerebri. This helps us to not overestimate or underestimate the age and represents a true measurement as set out by the guidelines for measuring these biparietal diameters. Now, this shows an example of measuring too low. So here we can see the sort of figure 8 shaped or the bilobed cerebellum. And this results in a falsely low measurement, so we can underdate our pregnancies if we take our measurement here. So here we're not seeing the falx cerebri, which we should see kind of extending from the forebrain back to the hindbrain here. We're not seeing the thalami, except maybe a little bit there, but that looks more like ventricles. It's not that perfect view. And then we're not seeing the cavum septum pellucidum. We're seeing the actual cerebellum here. And so knowing those landmarks is important for helping you determine if you're in the right spot or not. So taking a head circumference, the good news is we take it in the exact same plane that we take our biparietal diameter. So once you get that good image on your screen, you can take both measurements and you don't have to adjust your scan at all. So in this case, instead of taking the cross section, we fit an ellipse to go over the outer edge of the bony structures of the calvarium of our babies. And so you can adjust the ellipse by placing the diameter on the outer edge and then using your machine settings to fit the contour of the ellipse to the shape of the fetal head to get an assessment. Similar to the head circumference, the abdominal circumference relies on an understanding of landmarks so that we can make sure we're in the correct plane to get the most accurate measurement possible. The plane that we're looking for is a transverse cross-section of the fetal abdomen. And some landmarks that I want you to identify are the vertebral body, which I'll see here for you. And we know that's the vertebral body because it's hyperechoic and it has posterior shadowing underneath it right here. So we can see that to the right. And then next we're looking for the stomach bubble, which is right here. Highlighted in purple now. And the intrahepatic umbilical vein, which is running inside the liver, which we can see takes up the majority of the fetal abdomen. Just like we didn't want to see those cerebellar hemispheres on the head circumference, we also don't want to see the kidneys on this view, or else we know we're not quite in the right plane and probably too low. To take our measurement, we put our calipers on the outside, and you can see this person's already measured this. And we look at the outer edges of the fetal skin lines. Now, this is the most variable of all of the measurements that we take in fetal biometry, and most of that is because getting this particular angle can be super challenging. So it takes a lot of practice to be able to manipulate your probe while at the same time not avoiding a baby that's moving too much and all those other things that can complicate this view. The last of our measurements in fetal biometry is the femur length. The femur should be positioned perpendicular to the ultrasound beams as they come in, and rotate your probe to view it in the longest axis possible. Now this can be kind of a challenge, so my trick for this is try to get the bone, whenever you do see it, in the middle of your screen, because oftentimes you'll catch it in a cross section first or at an oblique angle. Once you get it in the center of the screen, then keeping it in the middle of the screen without translating the probe, just rotate the probe. And when you rotate, you should be able to see the longest axis come into view. And then if it slides off, press freeze really fast and you can scroll back in time using the scroller ball, and that can help you get the image that you're looking for. You'll place the calipers on the outside edges of the ossified portion of the diaphysis, and if you do happen to see an epiphysis, that is not included in your measurement. So you take from one length to the other, and this is the most accurate ultrasound measurement of the second and third trimester. While not necessary to complete a limited second or third trimester ultrasound, one of the most commonly asked questions when I do these ultrasounds by moms is, oh, can you tell if my baby's a boy or a girl? And while this is less common now that we have cell-free DNA testing that helps us determine the gender with greater accuracy and earlier in the development of a fetus. This is still a fun and useful skill to have, especially if you're in an area where you don't have access to advanced testing like fetal DNA testing. So here we can see something called the caudal notch. The caudal notch is a nub of developing genital tissue, and the reason that this caution sign is over here is because it can be mistaken sometimes for male genital tissue in both female and male babies. So we see that both females and males do indeed have this caudal notch or this genital nub. And it's less about whether or not it's present and more about the angle of that notch to the developing sacrum that helps us predict which sex to assign baby. So in females, that angle will be approximately parallel or slightly negative, like a 10 degree, negative 10 degree angle to the plane of the sacrum for that genital notch. And then here in males, you'll see it's a positive 30 degree angle from the developing sacrum down here. So that's how you can tell which one is which, with the positive angle being for males and an angle of -10 to parallel for females. So as a review for second and third trimester ultrasound, we talked about fetal lie and presentation. We examined the introduction to multiple gestations and how to determine their chorionicity and amnionicity. We talked about assessing amniotic fluid using the deepest vertical pocket, looked at some placentas and tried to verify where that location could be and understand the risk of placenta previa spectrum. We talked a little bit about growing babies and fetal biometry. And lastly, we used a neat trick to estimate the fetal sex when looking on an ultrasound.